Welcome to AETCM. ചേട്ടൻ
ഈ പറയുന്നതെല്ലാം സാറ് കാണുമെന്ന് അറിയാലോ അല്ലേ? ഓക്കെ.
Welcome to AETCM, the emergency medicine channel. Shall I? Today we'll be presenting a case of 47-year-old male who presented with sudden onset of breathlessness since 2 hours, and the patient was taken to the outside hospital and referred to our hospital. On initial 10-second assessment, patient was conscious, oriented and obeying commands, but patient was not able to complete a full sentence. Patient was maintaining a saturation of 84% at room air, so patient was connected to oxygen via mask. Airway was patent, no secretion, no gurgling and no pooling of saliva. Breathing, bilaterally reduced chest movements, and on auscultation reduced air entry bilaterally, and there was no added sounds. On circulation, patient was maintaining a BP of 140/90 mmHg, pulse rate of 84 per minute. All peripheral pulse were felt. At this time, 2 large IV bore cannulas were put and the patient was connected to the cardiac monitor. Since there was bilateral reduced chest movements and reduced air entry, we were suspecting of pneumothorax. So point of care USG was done, which showed an absent lung sliding in both sides. On M mode, we got a barcode sign. Meanwhile, we had arranged for a chest X-ray and we arranged 2 ICDs. On chest X-ray, we confirmed that there was bilateral pneumothorax at the level of the hilum. Intrapleural distance on the right side was 5 cm and on the left it was 3 cm. So ICD tube was bilaterally inserted simultaneously at the 5th intercostal space anterior to the mid-axillary line and kept under water seal. Coming to the disability, GCS was 15 out of 15. Pupils were equally reactive to light and moving all 4 limbs. On exposure, patient was febrile and GRBS was 110 mg per deciliter. On adjuncts to the primary survey, ABG was taken, which showed a pH of 7.2, PCO2 of 64, PO2 of 63, bicarbonate of 27 and lactate of 2, which showed a respiratory acidosis with type 2 respiratory failure. CBC CRP was sent to rule out any infective etiology. Total count was 9,000 and CRP was 30. Sample history: 47-year-old male, known case of osteosarcoma with lung mets, presented to ER with complaints of shortness of breath since 2 hours. The breathing difficulty was progressive in nature. Initially it was of MMRC type grade 2, which progressed to 4. There is no history of orthopnea PND, no history of chest discomfort or palpitation, no history of fever or cough. On examination, patient was conscious, oriented, no pallor, icterus, cyanosis, clubbing and lymphadenopathy. On respiratory system, on inspection, there was decreased chest movements bilaterally, no tracheal deviation. On auscultation, air entry was bilaterally reduced. On percussion, hyperresonant bilaterally. Other systems were within the normal limit. Then 2 ICDs were put bilaterally, and after ICD insertion we had taken an X-ray to confirm the ICD position, and then ICD were in the pleural space. Patient after ICD insertion improved and the saturation improved to the 95% on room air.
Fine. Let's start from beginning. So this patient presented to emergency with acute onset breathing difficulty for past 2 hour duration. So very sudden onset breathing difficulty. On your initial 10-second assessment, patient is tachypneic but with full consciousness and obeying commands. So patient has mild respiratory distress, right? Tachypnea alone. There is no use of accessory muscles or anything like that, but the patient is on oxygen. So when you do your airway assessment and breathing part, you told there is bilateral decreased air entry, decreased chest wall movements are there. You suspect a pneumothorax there. What is another important clinical feature you should look at that point of time?
Whether there is any hypotension.
Yes. So hypotension is one thing. So that comes in circulation part, right? But hypotension should be looked along with this. What is another clinical sign you look for?
JVP,
Not
elevated distended neck veins.
Distended neck veins. So if you see a distended neck veins in breathing with bilateral decreased air entry or a absent air entry or even unilateral absent air entry, as emergency physician, you should think about tension pneumothorax, and your role should be to actively rule out tension pneumothorax there, because if it is tension pneumothorax, you will hardly have maybe 15 to 20 minutes before the patient collapses. So that is first time. So distended neck veins is one thing you should be on the lookout for. On circulation, you will look for tachycardia with hypotension. So tension pneumothorax, right? You will have to rule it out. So if there is no tension pneumothorax, when will you intervene?
We'll take
Will you intervene at B, breathing, or will you intervene after primary surgery?
If bilateral pneumothorax is present, then we can intervene. Either hemodynamically unstable patient, or if bilateral pneumothorax is there, then we can go for the ICD insertion.
Why?
According to the BTS guidelines, we could go for the intervention if bilateral.
There should be a reason for no. According to BTS guidelines, true, but why? Why?
Patient
Because
is severe.
pneumothorax is a progressive condition. Patient is developing pneumothorax as we speak. So if bilateral pneumothorax is there, the patient doesn't have one lung to accommodate when you are doing the procedure. Patient worsening will be bilaterally worsening. That means patient will crash. That's why you intervene in B itself, that is in breathing itself. You don't wait for adjuvants or secondary survey, everything, because the patient doesn't have a physiologically normal lung to accommodate the time. But if this patient is having unilateral pneumothorax, there is adequate time because at least one lung is affected. This will also depend on what is the patient's condition or underlying lung disorders. For example, what are the types of pneumothorax that you know of?
Spontaneous, that can be divided into primary and secondary. In primary, there is no underlying lung disorders. In secondary, there will be a diagnosed underlying lung disorder. Then it could be traumatic, then it could be iatrogenic.
The traumatic is basically iatrogenic or due to trauma. So 3. So here it is if it is spontaneous secondary pneumothorax, it depends on patient's existing lung condition. So patient is oxygen dependent, or patient has low reserve volume, for example cystic fibrotic patients, or patients having fibrotic lung cavities, or already have done a lobectomy. These patients are extremely sensitive to loss of tidal volume, so loss of saturations. These patients you may have to intervene even though patient doesn't have tension pneumothorax features, because as the patient worsens, they have more chance for hemodynamic instability. So it's better to intervene earlier than late. Okay, so you have primary, secondary, means spontaneous pneumothorax, right? So you have spontaneous primary and spontaneous secondary. What is the difference between spontaneous primary and secondary? A diagnosed lung condition. It's not diagnosed lung condition, it's basically a affected lung, like whether the patient has a pathology that secondarily caused pneumothorax or not. So even if patient is not a known case of any disease condition, you do CT scan of the patient. Post pneumothorax, you do CT of the patient. It shows patient is having bronchiectasis or bronchitis or COPD. That is secondary pneumothorax. So even though a patient comes and tells you I have no comorbidities, now I develop pneumothorax, even though you may put a diagnosis of ESP, spontaneous primary spontaneous pneumothorax, initially the CT of the patient should not show any already existing pre-existing lung condition. If a pre-existing lung condition is there, the diagnosis will change to SSP. Okay, secondary. So what are some of the pure primary spontaneous pneumothoraxes?
Bullae rupture can be there.
Pre-existing bullaes, usually it's apical bullaes that can exist, usually seen in what type of patients?
Thin and tall patient, Marfan's.
Thin, tall, male patients, usually below the age of 30 years. Or
Marfan's syndrome.
Marfan's syndrome patients. Any other particular group of patients from some geological locations, high altitude patients can also develop primary spontaneous pneumothorax. All other conditions widely comes under secondary spontaneous pneumothorax. So in secondary spontaneous pneumothorax, can we discuss some of the condition that predisposes the patient to develop pneumothorax?
Patients of COPD history.
Most important is COPD. More than 55% of pneumothorax, secondary spontaneous pneumothorax are secondary to COPD. So
Old cases of TB, interstitial lung disease like bronchiectasis, cystic fibrosis, any malignancy, secondary mets to the lungs.
okay. Any infections can cause?
Yes, pneumonia, necrotizing pneumonias can cause.
Usually caused by what organisms?
Klebsiella can cause staph, strep.
Yeah. So in pneumococcal formation, pneumonias can form spontaneous, means secondary spontaneous pneumothorax. So pneumonias are second things that you should look for, and previous TB, active ongoing TB, previous TB with cavities, fungal infections, aspergillosis, these things can develop spontaneous pneumothorax, secondary spontaneous pneumothorax. Then you have traumatic. So traumatic is divided into iatrogenic and pure trauma induced. So blunt trauma. So if it is a traumatic pneumothorax, what are the different types of pneumothorax you are looking there?
Open pneumothorax and
a closed
pneumothorax.
Yes. Open and closed pneumothorax. Now, what is the difference between an open pneumothorax and a closed pneumothorax?
Open pneumothorax, the air gets, during inspiration the air gets sucked in and the intrapleural pressure will be almost equal to the atmospheric pressure.
Okay.
In closed pneumothorax, air is not going out.
Okay. So basically, open pneumothorax is like a two-way valve. Patient during each inspiration, air gets sucked in direct to interpleural fistula, interpleural space, so that the affected area lung will be collapsing and the entire mediastinum will shift to the affected pneumothorax area. Okay, so whenever, for example, right side there is a pneumothorax, open pneumothorax, each time you take a breath, there is pneumothorax filling up, so the right side air will be collapsing, lungs will be collapsing, and the mediastinal shift will be towards right side, not opposite to right side, towards right side. And each time patient expires, some amount of air will go out. But this is a progressive pneumothorax. This will not be a static pneumothorax. Progressively, patient will develop tension over here, because the amount of air going out during inspiration will never be equivalent to the amount of air getting inside, because the right side lung will progressively collapse into a state of non-dilation. Okay, till that happens, the mediastinum will always shift towards the affected side on inspiration and away from affected side on expiration, which is contradictory to the usual pneumothorax. As the pneumothorax worsens, the trachea is shifted opposite in normal pneumothorax, but in open it is this like this. So what is the primary treatment for an open pneumothorax? You have a traumatic patient in front of you, you have a penetrating injury to the right chest wall, and you are suspecting an open pneumothorax. How do you diagnose an open pneumothorax? There will be air coming out through the penetrating trauma. That is the easiest thing. Yeah, gushes of air will be there. What is the primary treatment you will do?
Strapping, sealing can be done.
Sealing of the pneumothorax, of the hole, right? No. You should never close a open pneumothorax. Why?
Close.
Three-way.
You have to put a three-way closure. What is a three-way closure?
Only three sides are closed with the strap, so that when during inspiration it will close itself.
Yeah. So basically you are making a one-way valve. You are closing open pneumothorax, that is a bidirectional pneumothorax, to a unidirectional. That is, during inspiration, you are closing it with a preferably plastic or a moldable material, and you strap it to the chest wall using three sides and leaving the bottom part of the covering as open. So each time when you suck in the air, the interpleural negative pressure will close the coverage completely, preventing air from getting into the pleural cavity, and whenever you expire, the increased pressures will push the air out. So basically it's a one-way valve. You can put the one-way valve, then you can insert a ICD to remove the excess air. Where will you put the ICD? In a open pneumothorax. For example, open pneumothorax is at the fifth intercostal space on the right side. Where will you put ICD? Above, below, or at the level? Can you put it through the pneumothorax? Means through the open pneumothorax? No. That is the first thing. You can't use the already existing penetrating injury to put a ICD. That is the first thing to rule out. Then, do you put it below or above? It's above. So wherever is the open pneumothorax, above that site should be taken for insertion of ICD. And the three-way closure should be kept in place. So that is open pneumothorax as such. Then our classical closed pneumothorax is there, usually caused by rib fractures penetrating onto the pleural cavity or lung contusion causing small alveolar pleural fistulas causing pneumothorax. Our classical ICD insertion is being done. So ICD insertion for closed traumatic pneumothoraxes and spontaneous pneumothoraxes are all same. Question is, in whom will you put a ICD and whom you don't have to put a ICD? Is there any criteria to define what type of patients you have to put ICDs and not put ICDs?
BTS guidelines.
Okay, so what does BTS say?
In spontaneous pneumothorax, if it is bilateral or if the patient is hemodynamically unstable, then we go for ICD insertion. In primary spontaneous, we look for the size of the pneumothorax. If it is more than 2 centimeter, then we can go for needle decompression. And if it is less than 2 centimeter, then we can observe the patient for 24 hours and then go for discharge of the patient. In secondary cases, if the size of the pneumothorax is more than 2 centimeter, we go for ICD insertion. 1 to 2 centimeter, we go for needle decompression, and less than 1 we go for oxygen therapy. Even if there is no hypoxia, also we go for the oxygen
high flow
therapy.
oxygen to facilitate reabsorption of intrapleural air. So we are saying more than 2 centimeter, less than 2 centimeters, 1 to 2 centimeters. Where is this 2 centimeter?
At the hilar level.
That is very important. You should know where to look for this 2 centimeter, because the American guidelines say more than 3 centimeter at the apex. So at the apex to the apicular area more than 3 centimeter pleural margin is what the American Society looks for. BTS looks for at the level of hilum. So at the level of hilum should be very clearly mentioned. Otherwise 2 centimeter can be anywhere, right? Okay. So usually at the level of hilum, 2 centimeter means 50% pneumothorax is there. So that is something you can think about. Okay, so this is how you identify which patients to put ICD. So what ICD will you use for? What is the size of ICDs that you have, and
In
what
case
will you
of pneumothorax, we can go for the small tube ICDs, that is of the size 9.
French, 9 French.
And then for cases of effusion like empyema, where there is thick collections, we can go for higher size, that is from 10 to 14.
How many French sizes of ICDs are there? Or what is a commonly available size French? Size
They
is
use 26. 26 to 36 size. Adult.
26 to
46.
40. 26 to 40 plus, but from 26 to 40 is for adults or weight group more than 45 kilo. So you have neonatal, not neonatal, you have infants, pediatrics and adults. So infants, that is up to 12 years or weight less than 9 kg, it is 12 to 14 French. 12 French or 14 French. Then you have children, that is up to age weight group of 45 kgs. That you have 16 French to 24 French. And adults or weight group more than 45 is 26 and above. 26 to 40, 46, that can vary, but 26 and above. This is the usual way in which we select the French. But as you told, that what you told is not wrong. The difference is there are newer methods of intrathoracic tube placements now. Previously, ICDs means only one thing. It's a thick, clear plastic tube, and that is always inserted surgically. So surgical thoracostomies is what people used to do. Now there is a newer method, which is Seldinger's method. So needle thoracostomy with a guide wire placement and dilation of percutaneously inserted thoracostomy tubes can be inserted. So that is 9 French to 14 French. 9 to 14, 16 Frenches is being now percutaneously inserted. That is why you are getting a value of 9 French and can be used in pneumothorax. But what we need to understand is smaller the size of tube, less discomfort the patient has, much more patient compliance will be there, patient can be discharged home, all that positive attractions are there. The negativity is that it can get blocked with secretions. So if a patient is having pneumothorax with an underlying pleural effusion or a hemothorax, you should always go for a proper ICD with a bigger size, that is at least 20 French and higher, so that it won't get blocked due to debris. Second thing, the smaller the size, it can always get kinked at the level of insertion or between the rib spaces. It can get kinked and it can stop flow of debris. In pneumothorax, as soon as you insert a thoracostomy tube inside, the pneumothorax is, the tension is taken out. Once tension is taken out, the pneumothorax usually subsides within first 48 hours. And very unlikely it will last more than 48 hours. And any pneumothorax lasts more than 48 hours requires further evaluation to rule out bronchopleural fistulas. But so usage of a smaller size French tube is fine, given there is no underlying effusions that requires drainage. Fine. So tube size has been selected. So where will you put a pleural means thoracostomy tube?
In the 5th intercostal space anterior to the mid-axillary line, in the safety triangle, we can place the ICD tube.
Okay, so triangle of safety. So what are the sides of the triangle of safety?
The apex of the triangle is the axilla. The lower border is formed by the upper border of the 5th rib. Anterior is by the lateral border of the pectoralis major, and the posterior is by the lateral border of latissimus dorsi.
Okay, so within this triangle you can insert. Doesn't mean 5th intercostal space. So basically this is the upper border of 5th rib, that is 4th intercostal space. But when you say this is on a patient who is in a semi-recumbent position. So that is very important, because if a patient is in supine position, the diaphragm will be pushed upwards. So that part you should always be thinking about. In comparison to left side, right side, since liver is there, the right diaphragm can always ride upwards the more patient is in supine position. So in a semi-recumbent position or a sitting position, the triangle of safety is much more okay. But in a supine patient, especially in a patient who is having kyphoscoliosis or a reduced thoracic cavity disorders like a fibrotic lung or something like that, you should always make sure the diaphragm is not riding upwards. You can usually get it done with a ultrasound. Similarly, how will you identify 5th intercostal space?
By palpatory method, you can.
How will you palpate and identify 5th intercostal space? What is the
Second.
landmark?
Corresponding to the nipple.
Nipple line varies from age and sex. Nipple line is one of the most, what is the word? Unreliable thing you can use. Sternal angle. So sternal angle corresponds to usually second intercostal space. That is how. Is there any better method in which you can identify 5th intercostal space in a new emergency medicine department?
USD.
USD. Take USD. calculate the rib spaces. You can see the rib space and count. You don't have to use sternal angle. You don't have to think about whether patient is having a unilateral lobectomy done or any fibrous lung cavity is there. You really don't have to guess anymore. You can see the rib space and evaluate. So ultrasound guided marking of position is much more better rather than palpatory. Given you have the resource to do that, you should have. Or else always look for the landmark method. Okay. So how do you insert ICDs?
Initially,
Briefly, like the entire procedure is a bit long, but briefly.
Initially, take the consent from the patient and the bystander. Then, if patient is on some anticoagulants or antiplatelets, you have to priorly inform the bystander about the chances of bleeding, intrapleural bleeding, and then we give the pre-medication such as local anesthetics can be given. Usually, we prefer lignoclean plus adrenaline 3 mg per kg. Once that is given, then we go for the positioning of the patient. The patient can be in either recumbent position or the patient can sit upright leaning towards the table.
Yeah, but not in supine, right? Because they use this method, that's why they are not saying supine.
Then the arm should be abducted and kept behind the head.
Good.
And then we look for the see for the fifth intercostal space, and then we clean and drape. And then following the aseptic techniques, we insert the ICD. Incision is made at the point where we have taken. We have to put an incision of the size.
It is the landmark, fifth intercostal space where, like
anterior to the mid-axillary line.
Yeah. So anterior to mid-axillary, 1 to 2 centimeter anterior to the mid-axillary line is where you put a incision. What type of incision? Vertical?
Horizontal insertion is
horizontal insertion
of the size of the tube and one of the finger to pass.
Yeah, 5 centimeters of incision size you can put. You can increase the incision size as needed. Okay, each person may not have the same finger size and all, right? So you can increase as needed, but at least 5 centimeters, 5 to 6 centimeters incision length should be there. Okay.
And then we dissect towards to
then
reach.
You have 2 options. That is the only thing we need to mention here, because the entire procedure, we orally saying the entire procedure doesn't make any difference because it has to be shown or seen. And so oral explanation of the procedure is not going to benefit anyone. But 2 options. You can do a blunt dissection of the muscular layer, that is intercostal muscles can be bluntly dissected, making a channel from the rib space into the interpleural space, and once the channel is dilated, you can bluntly insert ICD using a artery forceps into the space. That is one method which is much more safer, but takes time, more pain for the patient, and it has to be a bit more labor intensive method. Or you can use a trocar. ICD is already comes loaded with a trocar. You can use the trocar to insert the ICD through the intercostal muscles into the pleural space, but the trocar movement should be highly regulated with your non-dominant hand, because if you don't identify that you have entered into the pleural space, you can hit the lung and cause significant damage, soft tissue damage, and more importantly, a bronchopleural fistula can be created. So there are 2 methods basically. You can either use a trocar or you can do a blunt dissection. Blunt dissection more safer, but more time intensive, labor intensive, and painful for the patient. Fine. So once a tube is in, how will you know the tube is in?
Gush, underwater seal you can see.
That is for confirmation. Usually if it is pneumothorax we are dealing with, the moment you pop the pleural cavity, you will get a gush of air. So that is very prominent. You will definitely get a gush of air. Once the gush of air is there, happened, the patient usually will be symptomatically much better. Then you can put the ICD, and how will you know at what level you need to fix the ICD?
ICD has mainly 3 openings. Yes. So that 3 openings should be there in the pleural cavity itself.
Should be inside the pleural cavity. And and the distance from the percutaneous layer or till the intrapleural space should be added onto the ICD. So ICD have markings, usually up to 20 centimeters, 22 centimeters markings are there. So once you have done the tunneling, or if you are using Trocan method, as soon as you are entering, you should note at what is the level of the third eye of the ICD. So that much distance should definitely be inside the pleural space. If it is not, the patient can develop, if any of the ICD's eye is outside the pleural space,
subcutaneous emphysema
this
can be
patient
there.
can develop significant subcutaneous emphysema, pulling air into all the subcutaneous space and developing edematous features. It's quite discomfort for the patient, not any life-threatening condition as such, but quite discomfort. So that much distance should be at least inside. In blunt dissection, we can calculate the space. In trocar induce, you should pre-note the distance that you require and insert. Fine. And you keep the ICD on an underwater seal and look for air column movement. If any residual air is still there, you will get bubbling. If not, there will be air column movement. Fine. So, in tension pneumothorax, is there any change in procedure? Same patient, tension pneumothorax, is there any change in procedure? Or do you do something before the procedure?
Needle decompression can be done.
Yes. Why needle decompression should be done? It's not can be done. It's always should be done. Why it should be done? Because tension pneumothorax is basically a race against time. You want time. However fast you take time to reach the pleural space, maybe 5 minutes, but you don't know in a tension pneumothorax you have 5 minutes. So better to do a needle decompression so that the tension part of the tension pneumothorax is relieved and patient's hemodynamics will not be worsening when you do the procedure. How will you do needle thoracotomy?
So we go for the second intercostal space, mid clavicular line, and then do the needle with the spinal needle. It can be done.
How will you do it?
Perpendicular, right?
You
Just
jab
insert
the needle down. You don't slowly advance it or aspirate and go deep, nothing like that. You take a spinal needle, jab the needle down around 5 to 6 centimeters, but that is very arbitrary. Each person will have different chest wall thickness, but 5 to 6 centimeters minimum, jab it down. You are not caring about whether it will injure the lung, because you are saying it is tension pneumothorax. Tension pneumothorax, usually the affected lung will be completely collapsed. So we are not expecting a lung there. Jab it down, remove the stillet and look for a hiss of air that is released. If you don't get a hiss of air, what will you do? Is there a possibility that you don't get a hiss of air? Can it happen? It can if you haven't entered the pleural space, or you are inside the pleural space and there is no tension pneumothorax. You mistook a simple pneumothorax as a tension pneumothorax. You may not get a hiss of air, but how will you know whether you are in pleural cavity or not? Don't connect with syringe and water at all. You can easily take 2cc syringe with some saline and just pour 1 or 2 drops onto the hub of the needle. You don't push it in, just put it over the hub of needle. If air movement is there, you will see droplets going away, like when you put the droplets getting splattered. That is the easiest thing. If you don't get it, you can think about introducing the needle a bit more down as such. Fine. So needle thoracostomy. So once needle thoracostomy is done and you are putting ICD, you will remove the needle or keep it there? It should be kept it there. Once you do needle thoracostomy, till you secure the ICD, the needle should always be there. It should not be removed out. Okay. Fine. Anything else? Anything else is there? How do you anchor a ICD-2?
With simple intermittent sutures we can.
No need of pursing sutures and all nowadays. Simple sutures are enough. You can first put simple sutures to reduce the incisional free space. Once the free space is closed, you can put simple sutures from the skin level onto the tube and tie it off from both sides. That is more than enough. Pursing sutures are not required nowadays. You get a patient in ER. Patient gives history of exertion dyspnea, long standing, 10 years, 5 years, 10 years, long standing exertion dyspnea. Patient gives history of severe breathing difficulty for past maybe 2 or 3 days, which is worsened on exertion. Patient has cough, patient has sputum production, patient is maybe mildly febrile, and on examination you get reduced air entry on left side. Air entry is present on right side, crepitations are there. Left side air entry is reduced, air entry chest wall movements are reduced. You take a X-ray to rule out pneumothorax. X-ray shows lower zone of the left side, gaseous presence, pneumothorax like. There is no lung markings there. So basically bronchioalveolar markings you get in a normal lung stone. So that is absent there. What will you do? Will you insert ICD or not? You got the question, right? Elderly patient, chronic exertion dyspnea, progressive exertion dyspnea for the past couple of days. Suspected history of LRTI is there. Crepitations are there, sputum is there, cough is there. On examination, but pneumothorax features are there on the left side. Absent air entry, decreased air entry, muffled lung sounds and or absent lung sounds. X-ray shows lower zone air pocket. There is no lung markings. Lower zone air pocket is there. What will you do? Patient respiratory rate is around 30. Saturation is 92 on air. Room means on oxygen. What will you do? Will you put a ICD or not? You will? You will? Or will you do something else? What is the role of ultrasound in emergency? Ultrasound for diagnosing pneumothorax in emergency.
Thanks, Lord.
Is it good, bad, or not needed?
Good. Needed.
It's needed, not only needed, it's really good because it's a adjuvant in emergency departments. You can make a decision faster and it will supplement your X-ray findings, or X-ray may take some time, so you can get ready with the things before confirmation. So what are the ultrasound findings in pneumothorax?
Lung sliding will be absent.
It's not maybe, it should be absent. If there is lung sliding, it's very difficult for you to say pneumothorax. Lung sliding should be absent. That is a sensitive sign. You have absent lung sliding, you have a highly sensitive sign that shows there is pneumothorax. But is it specific? No. There are other conditions that can cause absence of lung slide. Example?
Effusion.
Pleural effusions or
Empyema
hemothorax, emphysematous. Even an emphysematous lung can show absence of lung slide. What is the specific sign of lung pneumothorax?
Lung point.
Lung point. So what does a lung point mean?
At one point we can see lung sliding on one side and the
confluent
other.
side in which a normal lung sliding means pleural sliding and area in which absence lung sliding can be seen in a single ultrasound field is called as lung point. Fine. So you get lung point. That is a specific sign. Now why I told this is, any other DDs are there for a case that we discussed earlier? We told the case, no? One thing is pneumothorax. Any other DDs are there? Pneumotocele. Pneumatoceles usually it's like a significant area. Not significant area is very unlikely. Pneumatoceles can coalesce and form areas of pneumothorax-like features, but yeah, it's okay. Pneumatoceles is one thing. Then
Effusion. Loculated effusion, I got.
ancestor pleural effusions, but effusions are usually much more but radio opaque, right? In X-ray, you don't get radio lucent areas like pneumothorax, you get radio opaque areas, right? Fluid as well as blood. So this is radio lucent. I clearly told it's a air pocket. Lung collapse will again cause what? Lung collapse will cause volume loss. So volume loss will cause inter-rib space to be reduced, and the collapsed lung will form like a radio opaque area, or comparatively radio opaque than a normal lung, isn't it? What can produce a radio lucent sign?
Loculated pneumothorax.
Yeah, loculated pneumothorax. If patient already has previous TB or already has some metastatic lesions or pleural mets, there can be loculations, and this pneumothorax may be a loculated pneumothorax. So loculated pneumothorax is a thing. Do you have to put ICD for a loculated pneumothorax? Not from emergency. You can diagnose it with CT. You can wait for CT before putting a ICD into a loculated pneumothorax. So loculated pneumothorax, you don't require ICD as an emergency procedure. Then what else? Much more common. Bullae. This can be a COPD patient with a bullae in that area. You will be seeing a normal bullae, and if you put a ICD, you will be rupturing it, causing a pneumothorax. The thing is, you will never know whether it was a bullae or not, because you would have already ruptured it. So these patients, this patient, we told history-wise, it's not a pneumothorax history. There is a chronic accession dyspnea, there is a progressive accession dyspnea, on top of that there are features of LRTA. There is nothing for you to put a ICD then and there. You might have seen a pneumothorax. Doesn't mean all pneumothorax requires emergency intervention by putting a ICD. You can evaluate and find out whether it's clearly a pneumothorax or not. If patient is hemodynamic, it is stable. Okay, if you're not expecting a significant lung volume collapse or patient to be in distress or severe hypoxia. Worsening breathlessness doesn't mean distress. Worsening breathlessness, I clearly told it's a exertional breathlessness. Doesn't mean distress. Distress is tachypnic on oxygen. 92 on oxygen. You still have time to do a ultrasound or a higher examination. Because what is another DD? What is another DD for a left side loculated air pocket? Pneumomediastinum possible, but pneumomediastinum pushing in entire lung out of the way means significant pneumomediastinum. That means esophageal rupture or something. Such patient usually don't present with this history. This is incidental finding. Say? Herniation of gastric, upper gastric area onto the left side. That's why I kept on saying left. So you get a loculated air in left side without a pneumothorax history. You should make sure it's not stomach. So hearing gastric sounds and all is very difficult. You may not get, it may not be a complete gastric extension onto the thorax itself. But if you get any X-ray, you get bowel hostrations or bowel loops in the hemithorax, that is a good thing. Even if it is not there, ultrasound should be looked into whether diaphragm is being eventurated up. So left side pockets of air without actual lung collapse or lung marking, you should be a bit careful in putting ICD, because you put ICD, you are causing visceral damage. It's not only lung, visceral damage, significant complication. So lung, not only absence of lung, marking a lung border should be clearly seen. So that lung border should be looked into, especially if you have a patient in which you can make them stabilize with bronchodilators or oxygen or whatever, and you can go for a specific investigation to diagnose or confirm your diagnosis. Okay. Anything else? Nothing. Fine.